So moving on to epilepsy. So first of all, it's important to understand what epilepsy is. So if a person has two unprovoked seizures, which occur more than 24 hours apart, this is diagnostic of epilepsy. Or if they have one unprovoked seizure, and the probability of further seizures over the next 10 years is above that of the average person, again, they have epilepsy, or through the diagnosis of an epilepsy syndrome. And so it's important to know what the difference is between a seizure and what epilepsy is. So epilepsy is when they have repeated seizures or an increased risk of seizures, whereas a seizure itself is when a person presents with signs or symptoms of abnormal or excessive synchronous neuronal activity in the brain. And this results as a result of a uncoordinated or uncontrolled discharge of neurons in the central nervous system, and is characteristically stereotyped or uncontrollable in nature. So if a patient has seizures which are asymmetrical or different every time, or they say they're able to stop the seizures themselves, or they're sort of conscious during the seizures, or they're controlling them, that is not a seizure, that would be a pseudo-seizure. And then with regards to the diagnosis of seizures, it's quite important to take a detailed history, but I'll go over the history taking a bit further on. And so the lifetime incidence of epilepsy or seizures is about 5%, but most people tend to go into remission. The incidence is higher in developing countries as a result of parasites which affect the brain. In the UK, it's about 500,000 people, and 2/3 tend to be idiopathic. Other causes include tumours or vascular conditions such as arterial venous malformations, trauma, or infections, as I've mentioned. There are particular things which can trigger seizures. This includes sleep deprivation or physical or mental exhaustion. If a patient misses the dose of their drugs or underdoses, alcohol withdrawal or recreational drug use can trigger seizures as well. Flickering lights can trigger seizures in people with certain syndromes. Infections or metabolic disturbances such as diabetic ketoacidosis can trigger seizures as well. And then again, with particular seizure syndromes, things such as loud noises or music or hot baths can trigger seizures. And so seizures can be classified into either focal or generalized. And so focal seizures and generalized, I'll go into more detail with regards to the different types. But essentially with focal, it's when you have the disease process affecting a particular part of the brain or a particular lobe. And in some people, this can lead to secondary generalization, in which it affects the entire brain. In people with primary generalized seizures, this is when the initial onset of the seizure affects the entire brain. And so, as I've mentioned, there are certain clinical features or associated with the with seizures. And when you're taking a history, it's very important to pick out these features to know what type of seizure this person has, or if they actually do have a seizure. So you want to ask them what happened before the seizure. So before they had the seizure, how did they feel? Did they notice any flashing lights? Did they feel abnormal? Did they feel like vomiting? Did they did they do anything abnormal? Any abnormal rising epigastric discomforts? Have they had seizures in the past? Is there a family history? Do they have febrile seizures as a child? Have they had any head injury? Have they started any new medication? That sort of thing. And then during the seizure, they may not be conscious, so you may have to take a history from a family member. But with regards to this, you want to know, did they fall over? Did they hit their head? Were they moving about? Was it symmetric? Was it asymmetric? Was there an epileptic cry? Was there foaming at the mouth or a bitten tongue? Did they lose urinary or fecal continence? What was happening? So this is regards to, say, tonic-clonic seizures. And so what happened during the seizure is quite important to take a detailed history. And then afterwards, you want to know, did they feel tired? Was there any paralysis? Were they able to get up, stand up again and start moving around? That sort of thing. And then with regards to this, you want to know what the different stages of the seizure were. So the prodrome, aura, ictus, and post-ictal refers to the before, during, and after. Prodrome is abnormal sensations before. The aura is when they have signs or symptoms which indicates the origin of the seizure. The ictus is the seizure itself, and post-ictal are the signs and symptoms and disorientation associated with after the seizure. And so focal seizures can have presentations related to the part of the brain which is affected. And so if it affects the frontal lobe, it primarily presents with motor symptoms. And so there's something known as the Jacksonian march, where a seizure occurring in a part of the motor cortex, say it's the part of the motor cortex which represents the hand, then progressively moves up the hand, so they have a twitching or stiffness of the hand which moves up to the wrist, then to the upper arm. And this is known as the Jacksonian march, and it's shown in this diagram. So it first affects the hand, and then the wrist, and then up to the shoulder and the head. They may also present with automatisms, so characteristic movements such as grimacing or hip thrusting or moving of the legs, or Todd's paralysis. And after the frontal lobe seizure, they may present with something which is known as Todd's paralysis, where the muscle group which was affected is unable to be moved. It tends to occur during sleep as well. And then another type of seizure which affects the frontal lobe is something known as an aversive seizure. So what I described with regards to the Jacksonian march would be a focal seizure. So the patient will be conscious during the seizure. However, with aversive seizures, it's effectively a frontal lobe's focal seizure with generalization. And so they have sudden uncontrolled head turning to a certain direction, which is then followed by a tonic-clonic seizure. So this diagram shows the person turning the head to the side, and then following this he may have a tonic-clonic. Seizures affecting the temporal lobe, again, so an exam, sort of like a characteristic thing you may see in an exam, is that they have a rising epigastric discomfort, or sort of they may hear music, characteristic music or a certain smell, or feel as if they don't really know where they are, they're lost, or that sort of thing. Very strange sensations before the actual seizure episode. They may also complain of automatism, so again repetitive behavior such as hip thrusting or grimacing before the actual seizure. And this may lead to secondary generalization with the tonic-clonic, which is and then in patients who don't have secondary generalization, they tend to have headaches and confusions after, say, a temporal lobe seizure. And it's typically associated with a history of febrile seizures as a child. Parietal lobe, focal lobe seizures tend to present with abnormal bodily sensations, which presents in a similar way to the Jacksonian march, so abnormal sensation in the hand which moves up the arm. Occipital lobe tends to present with visual hallucinations or flashing of lights. And so with this is a diagram. It's essentially like an overview of the focal seizures and the focal generalization, and with regards to different parts of the body. And then generalized seizures. So starting off with absent seizures. Absent seizures tend to be seen in children under the age of 18. Typical triggers are flashing lights or hyperventilation. It's characterized by a loss of awareness and a vacant expression, so the child will sit with their eyes open without moving, without speaking, for about 10 seconds, and then return to normal as if nothing happened. A typical presentation to, say, a GP is a parent that's complaining that the child isn't paying attention in school, or isn't responding to them, or is being naughty and not eating their dinner, but that's because they're having the absent seizures. And they tend to have multiple attacks throughout the day. And if a person has an absent status, this is characterized as an absent seizure with a very long period of clouding of consciousness. And with the investigation of absent seizures, there's a very characteristic feature, which is a 3 Hz spike and wave pattern, so shown in this diagram. So they have a spike, so here the spike, and then the wave, which occurs at a frequency of 3 Hz. So if you were to put an EMG on the head of a person with absent seizures, an EEG, the electroencephalograph, on the head of a person with absent seizures, and when they have the absent seizure, you would see this 3 Hz spike and wave pattern. Myoclonic seizures, again a type of generalized seizures, is characterized by brief jerking movements, so brief contraction of muscle groups, It tends to happen around the borders of sleep, so when you're waking up or going to sleep, and can be triggered by alcohol, fatigue, or sleep deprivation. And it's typically caused by benign juvenile myoclonic epilepsy, which is a seizure syndrome. And then there's tonic-clonic seizures, which is the type of seizure which is typically associated with epilepsy. It tends to be associated with an Ura, which indicates the origin. So if a person has, say, Jacksonian march followed by tonic-clonic, this indicates that the disease process is occurring in the frontal lobe and so on. So there are different stages. They have the rigid tonic stage, and they have the rigid tonic stage where they have increased muscle tone. The hands may be held in a position, or the feet may be extended. Following this, they have the clonic stage, where their hands and feet move in a sort of a clonic repetitive pattern, which is then followed by the post-ictal stupor, where the patient has a loss of conscious. And things to look out for are drooling, foaming at the mouth, a bitten tongue, loss of urinary or fecal continence, and a difficulty with moving the limbs. And this is characteristic for a tonic-clonic seizure. And there are also epilepsy syndromes. So I'm not going to go through all of these. I'll go through febrile seizures, infantile spasms, and benign Rolandic epilepsy. So febrile seizures. So essentially, in some children, following viral infections, the high temperature can cause the onset of a febrile seizure. It typically occurs in children between the age of 6 months to 6 years, but it does not cause brain damage. The risk of if a person has a febrile seizure, the risk of them developing epilepsy isn't above that of the general populace, but if the febrile seizure is prolonged, repeated, or severe, then they do have an increased risk. West syndrome tends to present between 3 to 12 months. It's characterized by violent flexor spasms of the head and trunk, followed by extension of the arms. And so this image shows something which is known as the Sellar position, so raising of the hands in children. And they may have many episodes of these per day. It tends to be associated with a difficult birth, so perinatal asphyxia or trauma, and the EEG would show something known as hypsarrhythmia, which is a very characteristic, non-controlled, disorganized pattern on the EEG. And these children tend to have an increased risk of disability and learning difficulties in the future. There's also benign Rolandic epilepsy. This tends to occur in children between the age of 4 to 10, where they have tonic-clonic seizures whilst asleep. They may also have a arrest of speech and hypersalivation afterwards, and they also tend to have paresis after the seizure. It tends to have a good prognosis, unlike West syndrome, and is associated with a history of febrile seizures. And so people with epilepsy or seizures, as I mentioned, it's important to take a very detailed history. You should also do further investigations such as a full blood count using these LFTs, bone profile, ECG, in order to rule out other causes of syncope. And this is what you do in patients who present with acute onset loss of consciousness. You want to rule out, is it caused by the heart? Is it the brain? Is it caused by something else? So thorough investigation. EEG and MRI as well. So with regards to EEG, essentially electrodes are put in the brain in order to measure the electrical potentials generated by neurons in the brain. However, this is not definitively diagnostic and is usually used in conjunction with clinical signs and symptoms, as patients who have epilepsy or seizures may not have epileptic spikes, and people who don't have epilepsy may also have epileptic spikes. And then there are different things you can do. You can do the EEG whilst they're sleep deprived for 24 hours. You can do stimulated EEG measurements where you actually flash lights in the patient's eyes or make them hyperventilate to induce the seizure. And then MRIs as well. So MRIs are typically indicated in people who is indicated in all people with seizure or epilepsy in order to rule out any potential, say, multiple sclerosis or infections or tumours which may be causing the symptoms, especially if the seizures occur before the age of 2 or in adulthood, or despite treatment or medication, the seizures tend to continue. And so these images essentially show temporal sclerosis. And so this is associated with herpes simplex virus infection, which can cause temporal sclerosis and increased risk of epilepsy in the future. And so the management of seizures can be acute or chronic or long-term. The acute management in people who have a seizure which lasts less than 5 minutes, you want to put them in the recovery position so initially when a person has a seizure which is less than 5 minutes, you want to protect the patient, move things out of the way, but not physically manipulate them. For example, maybe take off their glasses or move a cupboard out of the way so they don't hurt themselves. You don't want to hold them down. If the seizure goes away within 5 minutes, you should put them in the recovery position afterwards so that they don't aspirate their own potential vomits or aspirate any secretions. If it lasts more than 5 minutes, they should be given lorazepam. It's a benzodiazepine, it's either lorazepam, diazepam, or midazolam. If it lasts 10 more minutes after that, you would repeat this. If it lasts for 10 more minutes after that, it's phenytoin. And if it lasts for more than 60 minutes overall, you would want to give them propofol. And this, a seizure which is lasting more than 5 minutes, is something known as status epilepticus, and is a medical emergency which must be treated promptly, as it can lead to irreversible brain damage. So with the long-term management of epilepsy, the management differs between focal and generalized seizures. With focal seizures, you can use carbamazepine or lamotrigine first line. Second line includes drugs such as sodium valproate, levetiracetam, and oxcarbazepine. With tonic-clonic seizures, you can use sodium valproate, lamotrigine, or carbamazepine. With absent seizures, the treatment is ethosuximide or sodium valproate first line with lamotrigine second line, but you do not give carbamazepine or phenytoin, as this can cause worsening of absent seizures. Myoclonic seizures are treated with sodium valproate, levetiracetam or topiramate, but you do not give carbamazepine, phenytoin, or lamotrigine, as this can make it worse. And so another thing which typically comes up in exams is the pharmacology with regards to anti-epileptics. And so I'm going to go into detail with regards to phenytoin, carbamazepine, and sodium valproate. And so phenytoin, it has zero-order kinetics. So it's, for example, if you give a person a dose of phenytoin, the pharmacological response may be unpredictable. So usually you give them very small doses and increase it very slowly. And you also it requires blood monitoring for this reason. The characteristic side effects includes gum hypertrophy, acne, ataxia, thickening of the skin. And one of the ways that I remembered this was the mnemonic Hotmail GNK. So you can use this for your revision to remember it. Carbamazepine works in sodium channels. It's actually a modified benzodiazepine, and you tend to avoid giving this to patients who are Thai or Chinese, as there is a higher risk of Stevens-Johnson syndrome due to the higher incidence of HLA-B 1502 in people from Thailand and China. And sodium valproate, another thing which may come up in exams. The main thing to take away with sodium valproate is that it's teratogenic, and so this would typically not be given to women of reproductive age or women who are pregnant, as there is a very high risk of congenital malformations. All of the anticonvulsants or anti-epileptics are associated with teratogenicity and an increased risk of congenital malformations. However, sodium valproate in particular has an increased risk compared to the others. And then this is another mnemonic that I use to remember the side effects of sodium valproate. So moving on to brain tumours. So this is the last topic. So brain tumours are about 50% of brain tumours occur due to malignancy from other parts of the body. So not all of them are primary brain tumours. And they're more common with age. So 50% occur in people above the age of 65. In particular, with regards to metastasis, areas of the body where they tend to metastasize from include the lung, breast, stomach, prostate, and thyroid. With primary malignant, this represents 35% of tumors of the brain. These can be astrocytomas, oligodendrogliomas, ependydiomas, and medulloblastomas as well. And then benign includes meningiomas and neurofibromas. Another thing to note is that in adults, the majority of tumours tend to be supratentorial, whereas in children, they tend to be infratentorial. And so there's the notes are here for the pathology, but I'm not going to go through it in too much detail. The pathology varies depending on if the origin of the tumour is from astrocytes or oligodendrocytes and so on. And so with regards to astrocytes, this leads to astrocytomas, the most common type of primary brain tumour. Grade 1 would be pilocystic, so essentially hairy cytic, pilo meaning hair, cytic, and you can see this in the image. So it has a very sort of hairy appearance with dense Rosenthal fibers. This is more common in children and young adults. If it progresses, it can lead to grade 2, so this includes the diffuse types, fibrillary, gemistocystic, and protoplasmic. And this is characterized by a sort of flat, sort of pink, glassy appearance. And then grade 3 is when you have anaplasia. Grade 4 is glioblastoma multiforme. And then moving on, so oligodendrocytes, so it originates from the oligodendrocytes. These tend to be slow growing with a very well-defined border. So in this MRI, very well-defined border. You can tell where the edge of the tumor is and where the normal tissue is quite well. The pathology shows sort of round homogeneous nuclei with a fried egg appearance, and then grade 3 would be very anaplastic compared to the others. And then with ependymal cells, grade 2 typically occurs around ventricular canals or the ventricles, and then the nuclei tend to have a very well delineated appearance with perivascular rosettes. So in this image, you have a blood vessel here, so there's rosettes around the blood vessel. And then the anaplastic form, you have very pleomorphic, disorganized nuclei, very disorganized appearance. And then with the meninges, meningiomas tend to compress the brain rather than invade the brain parenchyma. Then there are different stages: benign, atypical, anaplastic. And then they can grow quite large with quite significant clinical effects. And then there's also schwannomas and neurofibromas. And so schwannomas, they're more common neurofibromatosis type 2. Neurofibromas are associated with neurofibromatosis type 1. And then tumours of the Sellar region. This includes pituitary adenomas and craniopharyngiomas. So pituitary adenomas typically present with bilateral temporal hemianopia, and so this is due to compression of the orbital chiasm, and so because you have docusation of fibers from the temporal region, and then this leads to a loss of vision in these regions of the visual field. And they can be large, so macroadenoma above 1 centimeter or micro below 1 centimeter, and they can be functioning or non-functioning. And so the presentation can vary depending on what the origin cell is. So if it originates from, say, somatotrophic, so growth hormone cells, it can lead to production of growth hormone, leading to acromegaly. If it originates from corticotropic, it can lead to Cushing syndrome and so on. And so it's quite important to recognize a person with symptoms of a brain tumor associated with endocrine symptoms as well. And so the presentation of brain tumors, the cardinal features are new onset seizures, personality changes, a disturbance of speech, headaches, and contralateral weakness. And so, as I've mentioned before, if it's a tumor affecting the cerebellar region, it can lead to cerebellar features, so Danish, as I mentioned before. And then, depending on the region of the brain where the tumor is, it can lead to different symptoms. So yes, as I mentioned, it depends on the position of the tumor. If it's in the frontal lobe, it tends to present primarily with motor features or motor symptoms and personality change. With the parietal lobe, again, it can present with motor symptoms and sensory changes. With regards to the 8th nerve, if a person has, say, a tumor compressing the 8th nerve, such as a vestibular schwannoma, it can cause sensory neural hearing loss. So that's another thing which can occur in exams. So sensory neural hearing loss associated with central nystagmus or central vertigo. And then because of the raised intracranial pressure, because the brain is a fixed box, and if you have an increased mass inside the brain because of the tumor, initially you have increased range of venous blood, and then CSF, and then it reaches a point where you have compression of the brain matter because of the fixed volume of the skull. This can lead to tonsillar herniation, so herniation which leads of the tonsils, or the cerebellar tonsils, compressing the brain stem. False localizing signs, so compression, if the tumor is in, say, the frontal lobe, the increased pressure may lead to compression of the fourth or the third or the sixth nerve, which makes you think that it's a tumor which originates from that region, but because of the false localizing or the pressure effects, it causes disease in other parts of the brain. And so this is essentially an overview of the different parts of the brain, of the different features or different presentations associated with tumors in different parts of the brain. And so with regards to the diagnosis of brain tumors, it's important to take a very thorough history and to do a thorough examination. So a CNS examination, lower and upper limb PNS. With regards to pituitary tumors which are productive, you should measure the levels of certain hormones, of the pituitary hormones, to determine whether or not a person has a functioning pituitary adenoma, for example. Blood tests such as full blood count, urinary, and liver function tests, because tumors tend to be associated with anemia of chronic disease, or if the origin of the disease, say, originates from the liver, the liver function test will be abnormal. If a person has a lung cancer which is associated with, say, a paraneoplastic syndrome, again, they may have a SAIDH, and the U's and E's will be abnormal. And if a person has, say, colon cancer, and they have anemia as a result of blood loss, the FBCs will be abnormal. And then again, if the metastasis is associated with a certain tumor marker, you would want to do this investigation. And then, so imaging of brain tumors. So with brain tumors, you can do CT scans and MRI scans. The CT scan is helpful for the diagnosis of the tumor. It helps you to know that there is a tumor, or there is a mass in the brain. It's important to recognize that a person can present with a mass in the brain which isn't a tumor and is in fact, say, a parasite, a parasitic cyst, or say bacterial cyst. In these cases, MRI with gadolinium enhancement can be very useful, as this can differentiate between, say, a cyst or different types of tumors as well. Furthermore, MRI is typically done as part of pre-surgical planning, as it provides a clearer image and a clearer delineation between normal tissue and the tumorous tissue or the malignant tissue. So with regards to management of brain tumors, glucocorticoids are given to reduce the inflammation, because the tumor can cause inflammation around itself, causing raised intracranial pressure. And this is usually done in an acute setting, so a person who presents to the hospital with the initial presentation of the disease with vomiting or tonsillar herniation or symptoms indicating raised intracranial pressure, you would want to give glucocorticoids, and so this would be IV dexamethasone. With regards to chemotherapy, this is quite detailed. It's better to understand that with the treatment of cancer, it's either treatment of tumors as chemotherapy, radiotherapy, or surgery. And with regards to the chemotherapy in brain tumors, there are different drugs which can be used, but learning this in too much detail isn't as important. Surgical management, it's again important to understand that with malignant tumors, it's not always possible to remove the entire mass, and you may have removal of normal functioning brain tissue as well. There are different routes for removal of the tumor depending on where it is. For example, the characteristic transfonoidal route for pituitary adenomas. There's also, say, craniotomies, and burr holes, and so on. And then, as I mentioned, with regards to the actual treatment of brain tumours, it's important to understand that the actual detail with regards to the treatment of brain tumours as a medical student isn't too important. It's important to understand what the overall picture is, as these sort of things tend to progress very quickly, and there tends to be a lot of change in the field over time.